my dear doctors. So, continuing our discussions about the neurology stations, and previous video I discussed about the myotonic dystrophy, which is a spot diagnosis. So, I've come with another case. This is also spot diagnosis, and it's quite common in the neurology station, Parkinson's disease. So once you enter the station and if you find that the patient has an expressionless face, and if you are able to elicit, if you're able to see some type of tremors, then you should just concentrate on demonstrating the specific signs of Parkinson's disease. Because no point in doing full neurological examination, we don't have time for that one. So if you think that the patient has Parkinson's disease like expressionless face, first of all, we ask the patient to walk, and mainly we are looking for the fascinate gait. You can also ask the patient to close the eyes because we want to look for any blepharoclonus. Ask the general question to the patient like how they are feeling today, what did they have for their breakfast, because we want to look for any monotonous speech. Test for cogwheel and lead pipe rigidity, and examine the small movements of the hand because we want to demonstrate the bradykinesia. Now, if you see the tremors are not obvious, but you're still thinking that the patient has Parkinson's disease, then we can ask the patient to count backward from 20, and normally the signs are exacerbated with this maneuver. We can also ask the patient to write something, and mainly we're looking for any micrographia. Don't forget that once, if you think that patient has Parkinson's disease, we have to rule out Parkinson plus syndrome. So look for any vertical gaze palsy, which is supranuclear palsy, so vertical gaze must be checked, and along with it cerebellar symptoms to rule out multisystem atrophy. So once you have gone through this your examination, then next step will be once you are examining the patient, you should in your mind thinking about the positive finding and then looking for that one. So what are the positive findings which you will be seeing in the Parkinson's disease? Already mentioned expressionless face, bradykinesia, patient will have monotonous speech, cogwheel rigidity at wrist, lead pipe rigidity at elbow, may have asymmetrical, coarse, pill rolling tremors, and these are exacerbated by thoughts, and less obvious on the movements. So it's mainly he's got resting tremors. Gait, forward stooping, narrow based, decreased arm swing. Normally it's an asymmetrical disease, so extrapiramidal signs will be more prominent on one side. Look for cerebellar or pyramidal signs for the multisystem atrophy, and vertical gaze palsy for the progressive supranuclear palsy. Okay. Now come to the important part, how you will present the case. So once you examine the patient, you should give good presentation to the examiner. So first of all, because we ask the patient to walk, so your presentation should be in the same order how you have examined the patient. So you can say the patient has stoop posture when walking, is a narrow base gazed and reduced arms swinging. When eyes are closed, there is evidence of blepharoclonus. Patient has a monotonous speech and of low volume. On examination of the upper limb, I noticed patient has pill rolling, pill rolling tremors of hands and bradykinesia, which is marked on whichever side you have, right side or left side. Patient has lead pipe rigidity at elbow. There is cogwheel rigidity at wrist. Tremors, these are exacerbated by mental activity. Patient head entering is typical of micrographia. The eye movements are normal and no cerebellar signs on examination. I like to finish my examination by looking at the observation chart, mainly looking for any postural hypotension or pulse strength. And finally, I want to do a mini mental examination to assess the cognitive function. Presentation is very, very, very important, because if you have done a good presentation, examiner has already decided whether he want to pass you or if you are not successful, and then it will be followed by some questions. So make sure your good presentation, which can last about 2 minutes or 2.5 minutes. So then there will be not much time for the questions. So common questions which can be asked. Actually, normally they ask about the medications used in Parkinson's disease, and we all are aware about the medication. Just to revise, we have O-carbidopa, then we have dopamine agonists like ropenetrol, we have monoamine oxidase inhibitors like selegiline, anticholinergics procyclidine, and apomorphine. So if you know the name of the drug, sometimes they ask, they will not give you a scenario, but sometimes they ask if the patient is young, which medicine is you would prefer. If the patient is old, which, if the patient has drug-induced Parkinson, which medicines you prefer. You can get all these once you, whatever notes you are reading or book you're reading, you can get all the information there. And the question they ask, which is quite common, is how you will investigate the patient. So remember, the Parkinson's disease is a clinical diagnosis, and once you're seeing the tremors and the rigidity, the diagnosis is quite obvious. Brain imaging normally is done because we want to rule out any other possibility which is causing tremors or any other lesions. But remember that the patient responds to dopaminergic agents. This is the, I must say, on the top of the list, we put this diagnosis point, that patient will be diagnosed as Parkinson's disease if there is any response to dopaminergic agent. So that's all about the Parkinson's disease. Again, I try to be very brief and to the point. You can always, if you want more information, always read the book. So these are the basics. I want to just give some food of thought. So what questions can be asked and how you will present the case. Okay. Thank you very much, my dear doctor.